Welcome back to Your Health radio and television program. I am Dr. David Morwood. I'm a board-certified plastic surgeon, and I'm so very pleased you could be with us today. This next segment on Your Health, I'm going to talk about cleft palate and cleft palate repairs. And I like to call this mini lecture or presentation, Cookies, Coca-Cola, and Cleft Palate. I first gave this mini lecture in South America recently, operating with a program called Rotoplast. Every year, I'm fortunate enough that the Rotary Club sends me somewhere to a developing country, somewhere, whether it's Southeast Asia or Central America or South America, to operate on children with cleft lips and cleft palates. I think it's pretty straightforward, or it's obvious to people why we operate on a child or even an adult with a cleft lip. But it's not so obvious why we might repair a cleft palate, and not everyone, in fact, knows what a cleft palate is. So I'd like to take this opportunity to do a little education about the cleft palate repair. Now, before we do that, let's briefly talk about the cleft lip and the difference between a cleft lip and a cleft palate. The cleft lip is what we can see. There's a split in the lip that will often extend up into the nose. It comes in various degrees of severity. Some can be just a little notch. Some can extend halfway up the lip. Sometimes the cleft lip will extend just the entire height of the lip. And as I said, it can also extend up into the nose. Now, the reasons why we repair a cleft lip are overall essentially obvious. The face is a social tool. Children who grow up with an unrepaired cleft lip are often treated as outcasts. They're ostracized. Some of these children don't even go to school. When they do grow up, their social opportunities and employment opportunities are often limited, and hence a cleft lip repair can dramatically change their life and, of course, give them opportunities that they didn't have before or don't have as opposed to a child with an unrepaired cleft lip. Now, what about the palate? Essentially, the palate is the roof of the mouth. The palate has a hard part of it that's called the hard palate, closer to the teeth, and there's a soft palate which is more posterior or behind the hard palate. So once again, the palate has two components, the hard palate and the soft palate. Now, there's one more structure that we need to talk about, and that's the alveolus. The alveolus is a ridge that goes around and in front of the roof of the mouth that serves as the foundation for the teeth. Now, a cleft can occur in just the soft palate. In other words, that's the part of the palate towards the back of the throat or towards the pharynx. Or the split or cleft can involve the hard portion of the palate as well. And sometimes the palate can continue anteriorly or forward, and it can interrupt the alveolus. And again, the alveolus is a horseshoe-shaped structure that serves as the foundation for the teeth. So, why would we want to, or why do we need to, or why are we so concerned with repairing the cleft in the palate or the split in the palate? Well, there are a variety of reasons why we do that, but before I get into that, let's talk a little bit more about the anatomy. Let's imagine, again, the palate as the roof of the mouth. If you continue to go above the roof of the mouth, you'll conceive or conceptualize that you will soon be in the nose. Now, that makes sense as we explain or think of the floor of the nose becomes the roof of the mouth. So if there's a split in the palate or a cleft in the palate, that means that the nose or nasal cavity can have a space or connection directly into the mouth. In other words, that normal structure or normal palate or normal barrier between the nose and the mouth is interrupted. And so the barrier between the nose and the mouth is interrupted, and the airflow can be greatly changed. Also, saliva can go into the nose. Also, feeding can be a problem, like milk can oftentimes come out through the nose when a baby is trying to suckle and they have a cleft palate. But most importantly, a cleft palate interferes with speech. Now, I'd like to explain that if I could. I do have a way of explaining this. It's a little bit unusual. But what I'd like to do is everyone to make a sound like this. O. Now we can make a sound like this. E. Now how about a sound like this? Ta, 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 ta. We can make a sound like this. Da, da, da. How about ba, ba, ba? Now there's one more important sound that I would like you to make. It's ga, 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 ga. Now, the point of that little singing explanation exercise is to help you to learn that the air starts in the diaphragm, well, starts in the lungs, and it's pushed up by the diaphragm, and it comes up the throat into the pharynx. And to shape a word or to say a specific word or a sound, there are various points where the airflow is interrupted, various valve points. We can have a valve with the teeth to say ba, ba, ba. We can have a valve with the tongue and the teeth, we can have a valve with the lips to say ba, ba, ba. We can make a valve with the tongue and the teeth to say ta, 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 or da, da, da. But when we make sounds like ga, 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 or Coca-Cola, or cookies, it's that soft palate acting like a flutter valve going up against the back of the throat that helps to distribute and direct the airflow either up into the nose and out or through the mouth, etc. And those valves or areas where the air is constricted or modified can profoundly influence the sound and how we say a word. So when the soft palate touches the back of the throat or pharynx effectively, that's what we call velopharyngeal competence. If there is a split in the palate or a cleft in the palate and a baby or child is unable to properly direct the airflow between the nose and the mouth, that's called velopharyngeal incompetence, or else VPI. So there are very sophisticated ways in clinics in the United States, in Europe, where we can measure the flow. We can actually do videoscopy. We can actually do nasoscopy, insert a very tiny little video camera to see how the palate is working, see how the airflow is being interrupted and directed. But there are some also simple ways when we're in a developing country to test a child's level of VPI, or velopharyngeal incompetence or competence. One of the basic ways that we can perform these little tests and to measure this is by asking a child to say words or to form words like cookie or Coca-Cola. Now, if a child has velopharyngeal competence, they will be able to articulate those sounds like cookie, because the airflow is being interrupted in a certain way and the air is directed towards the nose or towards the mouth. When there's a cleft, they'll struggle a great deal to make those sounds, and you might see them grimace or snort or struggle, and they might sound like cookie or Coca-Cola. They have a very difficult time saying certain words. And again, it's not only in English, it's not only in the English language that you need to form those sounds, or KKK, but in Spanish and in many of the Asian languages and Middle Eastern languages, etc., those guttural sounds, or having the sounds created by the soft palate touching the back of the pharynx, those are very important sounds. Now, how do we do that surgically? When there's a split, well, there's different ways. They're called essentially palatoplasties. There's different types of repair that we can do. We can do a hard palate repair. Of course, moving the soft tissue, we try to recreate the nasal lining or the nasal floor. We can recreate the oral lining with a hard palate repair. But the important process that we try to carry out, or important phenomena that we try to accomplish when we're doing the soft palate repair, is to reunite the muscles. There is actually a muscle, or some muscles, in the palate. There's the levator palatini. There's a palatopharyngeus back there, and these muscles work in as a team to very tightly and very precisely control the airflow and the way we shape words. And it's actually a very sophisticated neuromuscular mechanism. So in surgery, we'll sometimes do what's called a furlough repair. That's where we reunite the muscles and we do a double layer closure in a Z-plasty fashion to not only bring the muscles and lining together on the nasal side and the oral side, but we also will lengthen the palate to make it easier for the palate to reach the pharynx. Again, leading a child to become velopharyngeal competent instead of VPI, which is velopharyngeal incompetence. So, in summary, the number one reason why we repair the palate is to help a baby with speech. It's very necessary to have the palate intact to form certain words and to make sounds. Now, when do we repair the palate? Certainly in major cleft palate centers in the United States and Europe and in parts of Asia, we try to repair the palate before the baby tries to speak, which is roughly at about age 1. So if we can get the cleft palate repair done by about age 9 months, 10 months, sometimes a little earlier, sometimes a little later, that represents a tremendous advantage for the child. That's a very interesting point in the development of the toddler, because right at about that time, not only is a child trying to learn how to mimic sounds that he hears around him, but he's also trying to walk. He or she is also learning eye-hand coordination. So again, that period between 9 months and 15 months is very key in the development of a toddler. Now, if at all possible, we try to repair the cleft palate before the baby tries to speak at about age 9 months or 10 months. Now, if we miss that timing landmark, is it a waste of time to do the cleft palate repair? It's not a total waste of time, but certainly it's advantageous to do it at that very key time or in the golden period. I like to teach parents about the equivalent of placing a baby's leg in a cast. Say that at that key period where the baby was trying to learn how to stand and walk, say we put the baby's legs in splints, or even one leg in a splint or cast, and we did not allow the baby to learn how to walk at that 12-month golden period, well, certainly if later on we took off the splint or cast, the baby is likely to be able to walk, but he would be at a tremendous disadvantage. So again, the biggest reason why we repair the cleft palate is to assist with speech. There's some other less important, or I should say minor reasons, but certainly important. I mentioned feeding. A baby with a cleft palate in a developing country will have a hard time feeding and making a vacuum, again, because that flutter valve won't effectively touch the back of the pharynx. And the baby becomes a slow feeder, whether he's suckling with the mother and breastfeeding or using a bottle. It's going to take a long time for that baby to finish a bottle. And some of the food or milk, as I described, might come out the nose. Babies with cleft palates get more ear infections. Of course, once again, if that soft palate is not able to flutter valve up to the pharynx, then the baby can't make a vacuum, and the baby can't mimic the vacuum when you swallow in a strong way and to clear out the eustachian tube. So the eustachian tube in the middle ear doesn't get cleaned out or doesn't drained as another child would. Now, if the palate split, or if the cleft lip, or if the cleft palate extends anteriorly to the hard palate to the alveolus, then the whole dental lineup, the whole orientation of the teeth will be misaligned. And then again, we have to ask the orthodontist or oral surgeon or dentist to get involved to help us realign the teeth. So again, there are many reasons why it's important to repair the cleft palate, even though the palate may be entirely invisible as the child grows up. Again, cleft lip repairs are fairly obvious. The face is a social tool, and it gives the child a tremendous advantage to have a cleft lip repair. However, the palate, even though you can't see it, is of vital importance to speech, to lessen ear infections, for feeding, and as I said, to help the teeth line up properly, and so a child will grow up and to be just as strong and just a good speaker as his cohorts without cleft palates. I appreciate very much you listening to this segment of Your Health radio and television program. Once again, I call that Cookies, Coca-Cola, and Cleft Palates. I appreciate you being here again today. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this has been Your Health radio and television program. Please tune in again. Thanks very much for being here.